Well, hello everyone. Welcome to XPC Talks. So we're very excited to have Neeraj Sonalkar. I'm not sure if I'm pronouncing your name correctly, but we've met maybe a month ago at CareOps conference and really bonded over our interest in primary care. And today is going to be a bit of a conversation how we can reframe thinking about primary care through community engagement. And Neeraj will share a bit about his work at San Mateo, and I'll hand it over to you. So give us a little bit of background about yourself and what you've been up to so far in your career, and then we can go into the presentation and then have a discussion.
Wonderful. Thank you so much, Paulius. Thank you for having me, and very nice to meet you all. And yes, you did say my name correctly. That's
Awesome.
great. So hello, my name is Neeraj Sonalkar, and my background has been quite eclectic. So I started out as a mechanical engineer, but in my master's and PhD went over more to the human side. So went away from studying materials to actually looking at people who were creating products and developing companies. So my background has been a little on the product side. I have developed modular satellites for Lockheed Martin, and foot operated pumps for farmers in Myanmar, and everything in between. Not a lot of software actually. But then most of my career has been on the organizational design side. So I did my master's and PhD at Stanford, where I was fortunate to be part of the Stanford Design Group, as it was the D school as it was forming, and got a seat into that methodologies, those communities. I developed a couple of accelerators in India and Nigeria to help high potential founders using design principles and human centered design. So overall, went from product to organization to even ecosystems. How do you develop a regional collective where you have flows of information, talent, capital, and ideas creating new businesses? So after a long journey, where I have landed is in San Mateo Medical Center. Uh, and I'm currently heading innovation in primary care. So working with the CEO to see how we can actually create new models of care, within primary care, within a public health system. So that's a bit about my background. And I think what I wanted to talk about today, and have a conversation with you all. I get this meeting is recorded. Okay. Yeah. So have a conversation with you all. Is this project we are starting on, redesigning or reframing primary care access with the patient community? So I have a couple of slides to present, my perspective on what we are doing, and then we can go into a conversation on the topic. So let me start by sharing my screen. So I am coming to this field, not with a deep expertise in primary care or medicine. I'm coming mainly from a design lens. And if you look at the word design thinking, it's become very widely used nowadays. And much of the design thinking we know, the models of like 5 steps or 6 steps, starting with empathy, user research, brainstorming, prototyping, iterating, and so on, mainly come from the Stanford Design Group, and the work which was done by IDEO. But there is, in my research and the community that I was part of, we learned that it was not just a Stanford Design Group that was looking into design thinking. There were researchers all over, especially in Europe and Australia, who have done great work in understanding how do designers think. How do they come together to create products and come up with new ideas and new concepts, and what we can learn from them. And one of the seminal works in that is this book, Frame Innovation, by a good colleague and a friend of mine, Keith Dost. He is faculty in the University of Technology at Sydney. And he's a design philosopher. So he has gone out and studied product designers, industrial designers, to really understand their cognitive mechanisms. So the notion of framing and reframing, is mainly coming from this root. So let me share with you a story that Case shares. Before that, yes, what we mean by frame. Frame is a perceptual framework that categorizes what we think, what we know, and guides how we are thinking. Uh, so it's really an underlying perspective and underlying framework. So when we jump into an activity like primary care, there is a frame behind it. We are not always conscious of this frame, but through this work of designing, we can become conscious and choose to reframe if we want. So Case shares this story, of King's Cross in Sydney. I don't know if you have been to King's Cross before, but it is one of the suburbs of Sydney where there is a concentration of pubs and a lot of young people who go there, on weekends to drink and have a good time. I remember Case talking during one of the courses that we were co-teaching, and he mentioned there were around 30,000 youngsters who go there on weekends and nights to party, and that creates a problem. So there is a lot of alcohol-related violence, and the city of Sydney has been trying to solve this for a long time. So the city of Sydney sees this as a crime problem. There is crime happening here. And with that frame, they come in, they said, okay, what can we do? Let's add more police, to this picture. So they started having more police patrolling the streets. That didn't, solve the problem much. They said, okay, now let's have a police station in the middle of King's Cross. So they created a swanky new police station, and that just dispersed the violence. It did not reduce it. So then they said, okay, now let's look at the broken window theory. What if we beautify the streets and the alleys and the neighborhood? So we signal that here, people in this neighborhood care about each other. So we can actually try to, give subliminal messaging to try to reduce the crime. They did that, once again, not a lot of significant change. So they ultimately came to Case Torst Group in the University of Technology at Sydney and said, okay, what can you help us from a design lens here? Because we are tapped out. We have done a lot of these things that we thought which are within our remit, but the problem is not getting solved. So Case came in with his team and started looking at this situation and interviewing people, the party goers, the pub owners, the neighbors, everyone. And the first thing he realized was that this is not a crime problem. There is no crime here. It's just there's 30,000 youngsters wanting to have a good time, but not being very good at having a good time, apparently. So, what is happening really? So, they got all the data, the interview notes, their observations, they tried to make sense of it together. They looked at what had been done before, which is, at the intersection of alcohol and, violence and people coming together in large numbers. They looked at what makes this problem hard to solve. If it's not hard to solve, it should have been solved before. But there is some things here which is making this problem really, hard. They looked at who is involved, various different groups of people, not just the direct people who are involved, who are the police, the residents, the various party goers and so on. But there's also a lot of people around the center, who have some stake in the situation. And they looked at what's important to each one of them. What's important to the city, the venue owners, the patrons, the bars, and so on and so forth. So they did an extensive analysis of the situation, and then they tried to see, okay, what are the needs which are coming up from this picture? What are the themes which are coming up? There is a theme about sense of identity formation for the youngsters. There's a need for secure future, which is coming mainly from the business owners and the economic perspective, peace of mind, vibrancy, freedom. There were a number of themes that came up. And they dove into each theme into much greater detail. So, what does a sense of identity mean? And how is it formed? And what's the history of it? But this is what they realize is that, this is not a crime problem. We need to shift the way we think about the situation. We need to shift the frame. So, where else can you have 30,000 people coming together wanting to have a good time and actually having a good time, which doesn't result in crime or violence. And they thought of a frame of a music festival or a rock concert, people coming together, in very large numbers in a concentrated way, but things not going as wrong as they did at King's Cross. So they started saying, okay, what if we look at the situation from the frame of a music festival? What do we see that we haven't seen before? Can it change how we approach the problem? And it was a remarkable shift in the old frame of alcohol-related crime. The thinking was, okay, this is a crime problem, so we need more police, we need crime prevention, we need to reduce opportunities. There's a sense of security and safety which is needed here. Whereas in the new frame, it's really a frame about event management. It's about crowd control. It's about getting people in, letting them have a good time and then getting them out of that place in a proper way. Um, so this actually changed the way they were thinking about it, and then they looked at, okay, so if we look at the situation from this frame of a music festival or an event management, what are the challenges? And they quickly saw some key challenges which they hadn't noticed before. For example, they saw that the peak time of partying was 1 a.m. and the last train that left King's Cross was 1:20 a.m. and there was no train till 5 a.m. in the morning. So people, when they came in, were stuck. And taxis tend to be very expensive in Sydney, and in the taxi queue or the taxi line was where most of the violence happened. So, one easy solution from this frame is start more trains, ask the city to run more trains in the early hours of the morning. So it by itself is not a groundbreaking solution. But when you shift the frame, it changes how we think about that problem or that situation. Similarly, they created this notion of King's Cross guides. So there was, a particular group of volunteers who mostly did not drink, who were out there to guide patrons and say, okay, where's the next train station? There was a train station about 1 mile away where you could find trains running throughout the night, but most people didn't know about it. Um, so there were ways in which they could be guided. They created what they call as chill out zones, and they projected, light on the pavement and markers and maps, which were fun. But they also created other things taking from this metaphor of a music festival. For example, they found out that when you want to have a successful music festival, you cannot just have one event. Oh, sorry about that. I'm getting this thing in the middle. Okay. You cannot just have one event. You have one marquee event, one main stage, but then you have surrounding events that capture people's attention till the main thing gets going. And here in King's Cross, there were 2 or 3 main pubs, everybody wanting to get in, but nothing else. So they said, let's create small events, small chill out zones where there is little music playing, people can dance. There are little games they can play. And this is more like identity formation games. So you can, have a friendly match with your party that you have come with, and try to form identity in those ways, try to form connections in those ways. So they really shifted how the city of Sydney thought of itself from a crime and prevention council to an event management organization. This is one more thing they tried to do where they actually projected light on dark alleyways to make them more inviting and playful. So what is happening here, stepping back, is this, its design involves a very different form of reasoning. When we look at the normal logical forms of reasoning, we have deduction. If we know the what and we know the how, we can deduce it leads to a particular outcome. We have the inductive form of reasoning. If we know the outcome and we have a sense of the what, we can infer what the how might be. But Charles Peirce, who is a philosopher and one of the fathers of the American pragmatist movement, came up with this notion of abduction. Abduction is not induction or deduction. It's about having an outcome and maybe a how, but then kind of inferring, or it's hypothesizing, perhaps is a better word, hypothesizing what might be. And design takes it a bit step further, that there is a desired outcome that we're shooting for. We want to reduce alcohol related violence, but we have to figure out both the what and the how at the same time. It's about coming up with patterns and hypotheses and matching them and creating a frame which is a combination of those. So this was an example of reframing. And what I'm trying to do here in San Mateo Medical Center is to work with my colleagues to say, do we need to reframe primary care? And if so, how might we do it? Let me share with you the current situation that I'm in, and what I'm observing. So San Mateo Medical Center is a public health system. It is affiliated with the county of San Mateo, and we care for around 70,000 lives. So our primary care clinics, are tremendously backed up. Do you see these notifications? I'm not sure if you do.
Yeah, they do
Okay.
pop up, but it's all good.
Okay. Yeah. Sorry about that. I should have disabled that before. I didn't realize it afterwards. Okay. Let me get back to the topic. Yes. So our primary care clinics are very backed up. There are long wait lists. So people have to sometimes wait for months to get an appointment. Um, that's on one side. We have physician burnout in our system. We have a lot of physicians leaving, supervising physicians leaving. Being a county-based health system, we don't compensate as highly as some of the commercial systems do. So that's a challenge in attracting and retaining talent. At the same time, being the county system, it's more conservative in terms of use of technology. So we are now trying AI scribes and tools like that, but that's not really, moving the needle in any way. So overall, the sense I got when I first came here in November of 2023 was that, things are stuck, and doing little more of the same is not going to solve the situation. That we need to fundamentally reframe what primary care is for this system in order to make it unstuck, which is where this motivation is coming from. So this is the project that we are developing with our health plan, with the health plan of San Mateo. And the project is redesigning primary care access with the patient community. So we shared the story of King's Cross and the potential of design and, to reframe a particularly thorny and stuck issue, and suggested we could work with them to use it in the context of primary care. And we created this 4-phase approach. The first phase is ethnographic research, where we go out in the patient community. We talk to them, we observe what's happening. So we go outside the clinic. We go in the context in which the patients live and work, and try to understand, what does health mean for them? It's not just healthcare, it's not just primary care, but the notion of health itself. What drives them? What are their challenges? So see the world from their eyes, and this is what ethnographic research does. And then take that in, and then bring it to phase 2, which is co-design with the patient community. And by that, I mean that we would sit with a few members of the patient community and do an active reframing together about, what is good access to primary care, what is primary care, and see what comes out from there using the design methodologies, and take that and then go to phase 3, where we actually set up a small care team to do a pilot, where we care for around 3,000 patients. The hypothesis we are going in with is to, say that, okay, let's put that in the frame of a hybrid care model. So it could be face to face, it could be in the community, it could be in the clinic, it could be a virtual setup, or a mix of these things. But how it will be done, even within these channels, is to be designed with the patient community. And that's what we are trying to do. And then if that works, we get the health outcomes we desired, the engagement we desired, the financial sustainability that we desire, we can go to phase four, which is the scale and spread within the system. So currently, we are at the start of phase one. The health plan funded us for phases one and two because a lot of phase three depends on what happens in phase two. That budget and funding is determined based on the outcomes of phase two. So we are starting this work at this point. We are reaching mainly to our unengaged Spanish speaking communities. We have a majority Spanish speaking population, mainly Medical, some Medicare. So we are working with community partners now, to reach out to them and working with an ethnographic research partner, to do this work, to do the research part. So that's where we are. And what I thought I would, share with you is these questions. So, like, has primary care been reframed in the past? In your experience, how has that worked? How has it gone? Why shouldn't we reframe primary care? I see a need for reframing from my lens, but I'm curious from your lens. Is there a reason why we shouldn't do it? What challenges are you facing that might cue a need for a reframe? Reframes tend to be very expensive. Reframe is not the first way to solve a problem. It's only a way to solve a problem when you cannot do anything else, when things are extremely stuck. So it's an expensive way of approaching problem solving, but it can make a big shift. And then I'm curious what suggestions you have for this project that we are embarking on. So let me pause here.
So, hey, thanks so much for doing this presentation. Honestly, I learned a ton. That was really fascinating.
Thank
I
you.
will leave some room for people to volunteer to talk. Otherwise, I'll call on some friendly
Yeah.
faces here. Just maybe even start out with some general reflections of like what did people learn from this presentation? I think that tends to, instead of like digging into having an answer to a ginormous problem, kind of curious, what did you guys learn from reframing of like the violence to the crime to an event venue type of thing? Anyone want to volunteer?
I'll jump in. No takers. That was excellent, Raj.
Thank you.
I actually grew up in Australia, so I understood the King's Cross problem, even though I didn't grow up in Sydney itself, but been there a few times. Um, I can geek out on this whole design and primary care for days. Um, but maybe some of the things that resonated with me was things that we'd been through. So um, my business is Well Revolution. We're in New Zealand, which is where I live, and
Yeah.
also in the US. When we started out about 5 or 6 years ago, we were working with a clinical partner, which is a primary care group, which had about 100, 120,000 patients, exactly the same challenges that you're facing. And the problem was never coming up with a solution. The problem was always getting the people to change. That was always the biggest problem. Right. So we went through so many different processes and we sat in on all of their sessions when they were going through, all the challenges and trying to design solutions. And so in our business, we had a couple of really simple design principles. Yeah, because there's so many things you can try to follow and so many different frameworks. And so the two things we had was one was a quote from Dieter Rams, the industrial
Yes,
designer,
yes. Yeah.
which was good design is as little design as possible.
Right.
And then the other one was a quote from mathematician Jacobi, which is
Hmm.
invert, always invert. Right. So if you reframing is inversion. So you got a problem, flip it upside down and go, okay,
Right.
so
Right.
if we want something to happen is one thing. Okay, what do we don't want to happen? That's the inversion,
Mhm.
right? And
Mhm.
so whatever we don't want to happen, what leads to that happening, and let's not do that, right? And so that's the way we'd sort of work. And
Yeah.
so from all of this process that we went through, we decided to we'll just leave this alone because they were going on for months and months and months. So we went out ourselves and went into their communities and just spoke with people and chatted with people and all these sorts of things.
Yeah.
And so we came back to them with a couple of.
Oh, it freeze.
The internet. Oh, it was so
Oh,
fascinating what he was saying. Okay.
yes, that's the
But
cliffhanger.
then our argument back to them was, you say this the left side of your mouth, on the right side of your mouth, you're designing a solution which requires them to have high-powered devices, really good internet connectivity, because the telehealth solution is appointments and video calls. And so these people you're trying to help, which are like people on Medi-Cal or Medicare, and these are rural populations, low socioeconomic groups, and they don't have the latest iPhone 16 Pro Max, right? They have a $50 Android phone with very little to no internet connectivity. And so our solution was, let's not make them do video calls. Let's let them text, right? Because we don't have to
Yes,
teach people
yes.
how to send a text message. Grandma out in the country is already doing that. She doesn't need any education.
Yep,
So
yep.
that's the first thing they said no to. And then the second thing is, after everything we went through with, okay, accessibility, et cetera, blah, 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 the first thing that's getting in people's way is the need for them to make an appointment, right? Because the appointment is the thing that takes time. They have to go and search and hunt and find and schedule a time and do all these things, and then wait there 20 days, 30 days to see the
Right.
doctor. So we said, okay, why don't we just skip that, do no appointments, and just let them send a text and then go
Yep.
straight to a doctor, right? And they all said, no, you can't do that. Clinically not safe, et cetera, et cetera. So we did it ourselves. We didn't actually ever want to be a direct-to-consumer primary care provider. And so we did it ourselves as a proof point to say, look, here's a design project. We're going to do it ourselves. Let's see if it works. And it worked really, really well. So now that clinical partner is now rolling that out across their network. And it's the simple things like that. We always tend to make things too complex, right? And
Yeah.
I heard you're an engineer, went into medicine. I'm an engineer who got asked. I was the first mechatronics graduate in Australia, and they wanted me to go to do medicine, and I said no, thank you, because I didn't want to go study for another 5-6 years, or whatever it was going to take. And but it's the thing that we sort of learn in engineering is that um, here's a system, and we need to try to think about it as simply as possible,
Right.
because everything is complex, and if we try to deal with the complexity, we'll get nowhere.
Yeah, yeah.
Just a couple of random thoughts, but yeah, I can geek out on this stuff for days.
Yeah,
Someone else.
this is very helpful. This is very helpful. Okay, yeah, that's great. Yeah. Thank you so much. I mean, I think I resonate with a lot of that. I mean, we are thinking of similar lines of, like if we do something technology based, it will be text based for sure. But really, we are also curious about how does care fit into the lives of people who are busy, who are holding 2 or 3 jobs,
Mm-hmm.
who are not currently engaging. And if you look at the data we have about those who are not engaging in primary care and look at their utilization of ED or hospitalization, it actually tends to be much lower. So they're either relatively healthier or they have undiagnosed chronic conditions. Uh, and really figuring out, how does health fit in and what it means to them, and then designing
Mm.
service. So I would love to stay in touch and geek out
We
more.
did see exactly those sorts of things, and so you had people that if you make it too hard up front for them to
Right.
engage in that first step, they will just delay. They'll delay,
Got
put
it.
it off, or just forget about it, right? So
Yeah.
our solution literally was our original design proposition was, we want them to push a button and then go straight into a live chat with a GP, general practitioner,
Got it. Got it. I see.
and have that GP effectively help them on the spot, or figure them out and get them, triage them into an acute appointment or something.
Right. Right. Right.
And that really worked, right, from the patient point of view. What didn't work was getting the doctors to do it, right? And so
Yeah.
our clinical partner had 50, 60 GPs across their network, and they couldn't get them to do it. So what they did is they got us to do it for them. And so we
I
started
see.
out over the last 2 or 3 years. We've been doing it on their behalf.
Yeah.
Now that it's taken 2, 3 years for their own GPs to become comfortable and go, okay, we see patients like it. We see that it adds a little bit of work up front, but that work changes over time, and our lives get a bit better itself. So They're just, it's taken 3 years. They're just starting now to get their own GPs to do it. And even then, they're centralizing resources. So 3 years later, they're doing what we asked them to do at the very beginning, which was centralize a pool of GPs, pull in the right types of GPs from your network, and effectively run it like it's almost like a call center, but it's not a physical call center because people can be anywhere. Yeah. So we saw exactly those things. And so by enabling people just to send a message, go straight to the GP, that helped solve some of that engagement problem once patients knew about it. And you know who was most important in this entire process? Was the front desk team, not the doctors, not the nurses, not the practice managers, front desk.
Thanks for sharing that.
Thank you,
Brian. I was gonna either maybe call on Michael or David, because the startup is in their city in Philly, Fabric Health or Laundromat Health. I always mix it up, but where they basically go to people who are doing laundry at places, because they don't have their own laundry place, and then they basically either try to enroll them in Medicaid programs if they're eligible, or I think begin to do some screenings. It might have evolved since, but if y'all can comment on that. And I have a bunch of other examples, but I'll just kind of let others chime in first. Michael, O'Brien, or Dave, are y'all familiar with that company?
Dave's a little more familiar than I am, but it looks like Laura has her hand up.
Okay, that sounds good. We can come back to that.
I'll just say you're correct, Bias. That's the gist, is using third spaces with downtime to create high trust touch points, and then enrollment in Medicaid primarily. It's paid for by payers for the enrollment side, but it's really about spending time with the community, understanding the current problems, and building high trust relationships in spaces that are otherwise very devoid of those high trust, or have a lot of kind of the flipping the problem on its head, have a lot of low trust or distrust.
And just to add to that trust piece, thanks, Dave, about, like Black communities have historically been abused by the medical system, and there's a lot of trust issues, rightfully so. And so there's been a project, I forgot which city, related to controlling blood pressure in Black communities. And basically a barber is like a convening place where it's part of daily life to congregate there and socialize. And so they basically empowered barbers to screen for hypertension, and I think talk about it, do patient education. And there was a lot more uptake of, interventions and better outcomes. And this is published research. Just another, and there's actually 2 companies that are around that. And I know people there. So if you ever wanted to connect, I can dig up their contacts. Laura.
Hi, Neeraj. Thank you so much for that presentation. I live in San Mateo County, and I'm going to be so biased here. The fact that also my family is part of the health plan of San Mateo, and they're recipients of Medi-Cal. And I can tell you, and they're Spanish speaker, I can tell you firsthand that a lot of it is on that first touch point, which is either calling for an appointment. You probably already know with the data. I did this with my own startup. I talked to my sisters and everyone else, and I saw just the amount of time to get that first initial appointment. And I don't know if you have call logs, drop-offs, the time to take on that ethnography, you're going to probably see this. But I'm so glad to see that there's innovation at the Health Plan of San Mateo. I feel like a lot of being in Silicon Valley, I was very surprised and I know people that are building health tech in different types of aspects. For me personally, where I would probably tackle as well, where you can explore, is multi-generational approaches, where it's not just primary care for just the children pediatric or just geriatric care. Maybe having an approach that allows primary care access to the whole family. There's a lot of engagement, and you can get those appointments for your children, your mother, and yourself in one sort of visit in whatever capacity that is. It's kind of the crowd that you were talking about. Like you want to tell the crowd, disperse, but these families are not going to disperse themselves. They're still living. I live where I grew up. I grew up in Redwood City, and I live like, I used to live a block away from my mother, but not anymore because we couldn't afford it there. But yeah, definitely, like if you can think about those approaches of like dispersing that crowd is not going to help dispersing the families, and having the one person be engaged in the system, but maybe not the others. And so I think a lot of these multi-generational approaches, especially, would be beneficial to understand in the phase one.
Yeah. No, this is very valuable. The multi-generational approach, I had not thought about that yet. So this is very cool. Thank you. Yeah.
And
I would love to connect that to local. Yeah.
I'll add to what Laura is saying too.
Yes.
I used to work at a company that was doing value-based care around diabetic care management. So we were trying to reduce cost of care utilization. And to what Laura was saying, engagement of the family unit was one of our better success points of reducing cost. Because telling somebody to start moving and change what they're eating as a individual in a family unit that wasn't working towards that similar goal was a much harder uphill challenge. And so we would often subsidize the family enrollment and care, even if they weren't part of that program, because that was part of our cost savings. So I do completely agree with what Laura is saying. And I've seen other interesting approaches to that too.
Yeah, this is definitely a cool topic. Rob, we'll go to you in a second. Just to layer, in case we shift topics, but to layer on the family, I'll try to dig up a paper. One of the Southeast Asian countries, I want to say it's like in a rural place where like temples are really a big central part of life. And it's basically if a mother gets a diagnosis of diabetes, the entire family gets that diagnosis. And basically, a lot of, I think, food comes from the temples. And so basically, patterns of eating and going about life change for the entire family based on one member's condition. And I mean, it's really hard, I think, to execute in the individualistic country like the US, but I think just food for thought.
Yes.
Rob?
Yeah, actually, so I can just add a little bit of color to that specific point as well. But I have a separate frame, I think, as well to think about it. So I worked at a company that was a caregiver support company, and they were very much focused on, I think it helps more when you have a family caregiver who lives with the person who's suffering from whatever they're suffering from. And it was largely like a dementia focused program. But focusing on helping the caregiver take care of themselves so they can continue to take care of the what they call the care recipient, was like a critical aspect in helping to I'm gonna use this word exploit free labor. I don't mean it in a necessarily bad way, but the caregivers take on a lot of burden in those sorts of situations, and helping the caregiver take care of themselves so they don't burn out can help to reduce medical costs associated with the care recipients as well. So I think the family is definitely a big point. I come from sort of a different perspective in general. I spent a lot of time working on prior authorization at Epic primarily, and so my perspective on this is very much a reimbursement focused perspective. I think that I've sort of started exploring more deeply the direct primary care model, which is sort of what brought me here today. And the direct primary care model is everything's all screwed up and complicated. And so sort of a design thinking, as we discussed at the beginning, or an engineering perspective, like let's cut out all of the complexity. And of course, you can't always cut out the complexity of, your patients need to be able to pay for stuff. And direct primary care has subscription fees, which you may not be able to pay out of pocket. But there's a lot of innovation, I think, around health plans subsidizing the costs of things like direct primary care subscriptions, so that the doctors can still provide care in a way that is more relationship focused, which I think is part of what we've been talking about, and referring to throughout this conversation, is like, how do you get people to trust the system? And I think the doctor, being focused on spending time with someone, really getting to understand them as a person, is something that the direct primary care model really thrives with. And so if you can find a way to sort of fund that model, I sort of view it as a reimbursement problem, that you have all these very short appointments, these long wait times, and stuff like that. And so it seems like the direct primary care model might be a good one to look at to think about how to solve these sorts of problems in your context as well.
Yeah. No, this is valuable to think about it from a reimbursement lens. Thank you. Oh, yes.
Michael, take it away.
Yeah, well, thanks. I'll second a lot what Rob said. As a failed owner of a direct primary care practice in a working class community, I can attest to it. Sounds great. It's great from the perspective of the physician. It's great from the perspective of a community that's able to pay for it, but from a community that isn't necessarily able to pay for it or isn't used to the concept of a subscription model for preventative services, you have to take that into account. The way that the government is already mimicking that is through these capitated payment models, value-based care. That's pretty common in California. So, and I'm sure that, I don't know the health system you're in, but I'm sure there are capitated models around there for the Medicaid population. But leveraging that helps, which then is a lot about risk stratification. So it becomes a different world, and it's very difficult to get people who have only practiced in a fee-for-service hospital-based system to break their minds out of that place. Many health systems are challenged by this. The reframing thing I thought was very interesting. One of the things that was interesting about the Sydney story that you brought up is you could kind of see it was like the phrase we use in healthcare all the time is this incentive alignment. And in that story, it's really like everybody had a positive economic incentive in that narrative. There was no one really who was losing economic power other than maybe the city, right? But the city really wanted to reduce crime because they had an investment to increase the tax base. So they weren't going to just shut down. They could have, right? One solution, they could have just shut down, cleared it out. They did that here in Philly in kind of an area where it was kind of known as an open drug market. People weren't coming in. They just cleared the town, right? Just put police in and just cleared it, right? And so they didn't do that because there was an economic incentive to keep that thing going, right? It was a thriving center. And so they wanted to reduce the crime to increase the tax base and make the business more thriving. So there was all these aligned incentives. The cities wanted it to be cleaner. The patrons wanted it to be nicer. Taxi drivers wanted it to be more organized. The businesses wanted it to work better. The problem with healthcare is no one actually has the same goal. And you're in the worst place because the people who have the worst goal are the hospital. Their goal, if primary care works well, the institution that suffers the most is a hospital that's based on fee-for-service, particularly hospitals based on fee-for-service centered in low-income communities. I know this is a very controversial opinion. I share this a lot, but you're actually working for the enemy for the very problem that you're trying to solve. The only person who's benefiting from this horrible situation is the health system you work for. They won't admit that to themselves. They won't no one's going to actually say that. No one within the system actually conceives of it that way. But the economic incentives are to keep the population unhealthy. So they keep getting more caths. They keep getting more surgeries. They keep getting more things that keep the system alive. Now, people can push back, but value-based is supposed to solve that. So I don't know. I think it's important to note that the story you tell, it was easy to get all the incentives aligned of all the players in that narrative. It's not really clear to me that in your situation that's so simple.
Got it. No, this is valuable, Michael, especially the incentives perspective. Yeah, when I joined, this was one of the questions which I had raised is that who is the accounting balance sheet in service of, primary care or the clinics or the inpatient? And, the kind of answer I get both from the CFO and the CEO was that it's the outpatient which is driving the system more, which is an interesting perspective, And then if you look at it from, it is not run as a business, That's one of the things that both surprising and shocking at times. This is a county-based system, so it's driven mainly by the incentive. It has an identity and character of a safety net, and there is a lot of drive from the senior leadership to go beyond the safety net. How do we stop being a system of last resort and be a system of first choice, especially on primary care? Which is interesting, which is why they had me join and say, okay, let's do an innovation group on primary care and not on the ED or the inpatient side. But I do expect there will be tensions, like when things work out, there will be tensions.
This is really optimistic, and I know Michael would probably have like lots of things to say. I do want to just move the group along, and the cool part is that we're in the same community, and there are a couple new faces to XPC, but we can certainly keep this going if you're okay with that. Unless Michael, you like cannot hold back, you can definitely add a.
No, I was just going to comment that that's actually really interesting. Because you don't usually hear that from health systems. You usually hear the opposite, as Matt can probably attest to. That's actually really, really interesting.
So I'll post, there's Scott Connard did a talk on relentless healthcare about his experience where he got a primary care to function so well that a health system bought him out and closed them because they were at risk of closing hospitals. It's like a sad story because like they saved so much money and people didn't go to hospitals. So, that's what you're fighting against. And then to get at your initial question is like, how has primary care been reframed? Look up Gail Stevens' Intellectual Basis of Family Medicine. It is the origin story of our field. And it basically, one thesis there is that it's been a countercultural movement to like fragmentation of healthcare and over specialization in medicine and depersonalization and all of that. And that's why family medicine was started as a field, because basically don't have the luxury to say, no, this is not my body part. Like we are taking care of everything. And then there's at the same time, the biopsychosocial model was emerging, which is not just the biomedical model of disease. Matt, I think you were going to add something because I was going to transition to little breakout things if we have time, but it seems like people are engaging in the larger group, which is totally fine. Yeah.
There's also the warm-up period. The other one, and sorry, I jumped on a little bit late. I'll be honest, I couldn't figure out how to find the link. Is the Zev Newworth one to the Reframing Healthcare, but he has a specific chapter on reframing primary care and kind of this idea of, and so I go back to that image in that book pretty often too. I can drop the link in the chat, but I also really like that setup too.
Great. Sorry, who is this? You said which
Zev Newworth. He's over at Atrium, whatever that North Carolina one is, before they merged with Advocate. But yeah, I really his writing is like would highly recommend.
Got it. Okay. Yeah.
I'll stop the recording here. I'd love to ask Dave and Rudmila to turn on their cam if they can. I'll take a group photo for the yearbook that I'll maybe never make, but it's good to have those.